The most important thing is Y complex, okay? And it originates from intervention. Now, there's different type of mechanism. Some mechanism can involve reentry like this, and most of them is within the Purkinje fiber and muscle. And because it's in the muscle and in the Purkinje fibers, it is Y complex. Okay? So just quick definition: sustain, duration is greater than 30, non-sustain, less than 30. Okay? Monomorphic, everyone the same. Okay, the cars complex, and usually they come from this one focus. Okay, polymorphic, have different shapes. Cars complex comes in different shapes, and usually it comes from different foci or one single focus. We cannot tell. Okay, with multiple exit points, but we cannot tell. The most common form of polymorphic VT it will come across the torsade point. Okay, now, and usually it involve long QT. Okay, and so the characteristic is like this. Okay? It's a lot QRS complexes of different shape, but they twist around an isometric line. And I find the easiest way to describe it is like crescendo to crescendo murmur. The shape, the graphic representation, big, small, it's a twisting part, big again, small. Okay, so it's very characteristic. And usually associated with long QT interval. Now, so I also include the measurement QT interval. Okay, and and also how to correct for the heart rate. Okay, so QTC is QT divided by the square root of R. Okay, when you're atrial fibrillation, a little more complicated. Okay? So after correction, and this is the different formula. This is and the normal QTC interval is less than 450. Okay, around that. Okay, now, but usually we don't panic until the QT, whether QTC or QT become 500 or longer. Now, and also the easiest way to, as you may have learned, to determine whether the QT is abnormal is look at the QT and double that. Okay, 1, 2. Oh, it's longer than double that. Is longer than the previous R interval. That means that your QT probably is long, and you better look at it more carefully. Okay, now, so let's go to identification of VT, Y complex tachycardia. Now, many algorithms, I include 10 of them here for you. Now, the one that is marked, this is the first 6. The one that's marked with blue, okay, that is blue fonts. They're not diagnostic, but it's very helpful. Now, you have a QRS complex that's more than wide, more than 160. Now, make sure that you are not looking at delta waves, okay? And that is suggestive. Now, so absence of typical right bundle or left bundle morphology, that suggests VT, because sometimes you can have as I said, SVT with what? Right bundle, left bundle, give you a Y complex. Okay? And but you will see that in this situation, you see typical right bundle, typical left bundle, right? Now, if the QRS complex during tachycardia, okay, is in the northwest axis, okay, extreme axis deviation, then also suggests VT. Now, QRS is positive in AVR, okay, usually it's negative, and -1 and AVL, then it's a very quick way to determine whether this is in the northwest region. Now let's go to 2, 3, and 4. If you see any of them, then you can make the diagnosis of VT. Okay? Now, AV dissociation in the presence of YQRS complex. That means that you can determine, can show that the P wave and the QRS complexes occur at different rates, and they have no relationship to each other. Okay? And also the ventricular rate is faster than the atrial rate. That means that RR interval is much faster than the PP. Okay? So you can see that, you make the diagnosis of AV dissociation, and you have VT. Now, 3 and 4 are similar. Okay? One is called capture beats. Okay? What is capture beats? It means that like the atrial, the P wave, like AV dissociation. So even during tachycardia, the sinus node is doing its job and firing, at a constant speed. Okay? So, but every impulse, okay, cannot conduct to the ventricle. It gives you a normal sinus complex. Why? Because the ventricular rate, the VT rate is so fast. Okay, the ventricle is almost always refractory. Okay, and that also include the AV node. So the P wave never get down to the to the ventricle. Now, but once in a while, okay, if you're lucky, okay, it find a gap and come through and depolarize the ventricle. And when that happens, it captures the ventricle, and it means basically what it says is that what it means is that you have a QRS, a normal sinus complex. Okay? That's called capture beats. You see it, VT. Okay? Now, fusion complex is like a cousin of capture beats. That means that yes, it may be able to sneak through, go through the AV node, and get into the ventricle, except that part of the ventricle has already been depolarized, or at the same time being depolarized by the VT impulse. So what you have is a fusion, a dual depolarization of the ventricle, and that's why the fusion complex. What does it look like? It's not as narrow as and doesn't look like a normal sinus complex, but it's a lot less narrow than the normal the VT QRS complex. We'll show an example. Right? Now, so, and then you have 7, 8, 9, and 10. We'll use example to illustrate this. Okay. Now, let's look at the CCG. Now, this one actually I should show you a SVT with right on the branch block, okay? Because this one is not a challenge. It's quite complex, but there's a left bundle. I should change that. I should get you an SVT with a left bundle. Okay, so this one you don't have to invoke the typical left bundle rule because you can see P waves in front of every QRS complex, and it's positive. Okay, it's a full illustration. Now, okay, this one I'm trying to get at is how to determine AV dissociation. Now, so actually, let me go back to use this. Okay. Now, so if you look at this CCG, because if we're doing face-to-face teaching, I'll be handing out piece of blank paper and ask you to mark out mark the P waves on the piece of paper and use it as a ruler. So this is tachycardia, the QRS comes wide. Okay? But this illustrates a very important point of how to find P waves. Now, we already learned how to find P waves. But we'll see how we demonstrate AV dissociation. If you look at lead 2, any lead, but lead 2 is usually easiest, we can see the P waves. Okay? Now, you have the YQRS complex. Now, did you notice right here, there is something that comes in and out? Okay? Sometimes you see it, sometimes you don't. When you see that, okay, you suspect, number one, those are P waves. And you suspect that P waves have no deflection to QRS. So what would you do on a piece of paper is find the two most obvious P wave to you. Okay, so now let me see if I can use this one. Okay, and I'll say, all right, this is one P wave, right? And then I will say there's another P wave. Okay, pretty obvious. I'll make it, dark, more obvious for you. Okay, so this is your first interval. Now you use this interval and you move it over here. Okay, start another measurement. Oh, you notice that there's another deflection here? Okay, so 1, 2, and 3. In fact, you already demonstrate AV dissociation. Okay, now, so you can go again on this side, right? There's another deflection here. Okay. Oh, why? How come the next one is right here? Because you know what? We just picked the two most obvious one. In fact, there's one in between. The sinus P wave is actually shorter. It's a deep interval. Okay. See? There's another P wave here. There's another P wave here. So that's how you look for P waves and how you demonstrate AV dissociation. Okay. Now, let's come back here. So in fact, after careful measurement, you don't need to find all the P waves as long as find, to me, 3 intervals, 3 P waves that that of constant intervals or a multiple of 1 PP interval, and you get AV dissociation. Okay. Now here you can see it. This P is buried in the QRS. Now this is actually I find this in the textbook, and I think they overdo it. Did you notice that when there's a P wave hiding in the QRS complex, the QRS getting taller? It doesn't happen in real life. Okay, so you can see, buried, come out. So if you see AV dissociation, sometimes take a little work to do, extra work, and you have AV dissociation. Unfortunately, the QRS complex in general are faster, BT, and wider, and the P wave can never see the P wave. Okay, now, so we talk about fusion beats and capture beats. Let's see an example. Okay, now, the cardia, my complex, and then all of all the giants, this is spontaneous. It's a narrow, skinny guy, okay? And when you see that, it's either capture beats or diffusion beats. And you can shout out from the back of the room or in front of the room and say, hey, this is VT. Okay? That's how simple it is. Now, this will illustrate the capture beat. This look exactly the same as the sinus beat. But most of the time, you do not have the benefit of the sinus beat. But as long as you have some, in the middle of giants, you're getting skinny guy that is either capture or fusion. That's good enough to say that, hey, this is fusion, or this is VT. Now, illustration of fusion complex. You look at this wide complex of the cardia. Okay? They all look the same. They look wide except the two that are marked down as fusion complexes. Okay? So, and it's not as narrow as you would like, but it is different in shape. Okay? Different shape is good enough. This is an illustration of how it happened. VT, ventricle, the gray area, refractory, mild refractory period. So the sinus P wave still continue to work to do its job. Okay, come down. Sometimes in this case, AV node is still good. Okay, So come back here, hit the refractory period, hit the refractory period, hit the refractory period. Hey, this 2, it just happened 2. Okay? Now, it happens that this was able to come through, but unfortunately, at the shear depolarization of the ventricle with the VT beat, so you have a fusion complex. All right? Now, so the CCG, and you look at it and say, oh, what can this be? Okay? And number 1, you see the bottleneck. Number 2, you see a knockdown. The fusion complex is narrow. Okay? The key, narrow or narrower. Okay? And different shape. Okay? Or different shape. Not just narrow, different shape. Okay? It can just be different shape as a regular Y complex. And there's a fusion beat. You see that? It's VT. Now, why do I call this fusion? Because this is a sinus beat. Okay, P, QRS, P, QRS. And you look at this, it's not the same. Okay? And it's not the same because it is a fusion between this and this. Now, it's not equal partner. It depends on who occupied the ventricle first and most of, and how much the depolarization is due to which source. Okay, so in this case, I think most of the ventricle depolarized from a conducted P wave and go into the ventricle. Okay, so unfortunately, you don't see it often. You see it, you got it. Okay, now then, how about the rest? 7, 8, 9, and 10. Now, 7, so-called concordance, is not, again, not common. When you see it, you need to help. Now, you look at V1 to V6. And if they are all, the QRS complex is mostly, predominantly, is mostly, each one is negative. Okay, now this is a small R wave, but now even S wave is not bigger, so we call it negative. Even this is negative. So it's all negative, so a negative concordance. Okay, so in V1 to V6, yes, it's VT, but it's a situation in which you have a VT beat coming from the apex and the polarized ventricle in this direction, so away from V1 to V6. It's not as obvious in V1, but when you see that, you can call it VT. The opposite is the same, okay? Positive concordance. So now this apex is the base. So the VT complex pacemaker focuses here, and if you're firing from top to bottom, it's all positive. So all positive. And we see that in the V1 to V6 is VT. Often you don't see it now. Then the next field, there will be we have it's called the Brugada sign. The Brugada is a cardiologist from Spain, and all three brothers are cardiologists. Sibling competition. Okay. Now, so in this publication, he said that if you look at again the precordial leads, and and if you measure from the beginning of the QRS to the S wave, okay, and it's more than equal or more than 100 milliseconds, it means that there's conduction delay, okay, and that's VT, okay. Now, the key part, the difficult part, this may be the challenging part of difficult, is where is this the T wave or the S wave, okay. S. Now, in this case, you have this you can consider as a T wave. So now you say this T, this is the S. Okay. So if you see it, VT. We'll see some more example. Now, number 9 is the easiest for you to remember. And it's about the bunny ear, okay, the rabbit ear or the bunny ear. Okay. Now, most VT you'll notice as kind of like a bright bundle pattern. That means tall R waves in V1. Why is that? Because most VT focus is located in the left ventricle. Okay? So create a conduction delay in the right ventricle conduction delay. Now, so we take advantage of this. If you see this, you have this right conduction delay pattern and most VTR, and you can see an RSR prime like a right bundle. Okay? Now, sometimes like the second one, it can be all the way down here, so you have to look. Okay. Now, if the left rabbit ear is taller than the right, okay, then it's VT. Now, to help you memorize this rule, is the first peak taller than the second peak. Okay, sometimes left and right can be confusing, depending. That's what I said, whether the rabbit is running away from you or running towards you. Okay? So we call it the left rabbit ear. It's the first taller than the second. If the opposite is non-diagnostic, it may still be VT. Right? This, you see it, VT. Okay, the last one is the Josephson sign. Okay? Josephson is from Brooklyn and from Philadelphia. He died just several years ago. Okay? And if he said any leads, okay, look at the S wave and be QS, in this case QS wave, and you see the notching here. Notching here is sometimes very subtle. You see it anywhere, VT. All right. So those are the 10 points. Okay. In fact, the last few is the most important. Now let's revisit again. Now we got to set up his criteria. So he said, okay, of course, yeah. He said, if you don't see any Y complex, and if they're all concordant, yes, it's VT. If not, now this is how equal, you don't have to go. Of course, he put out to S in 100 milliseconds without a sign first, because it's his sign. But you can find maybe dissociation right away. This you need to go through it. This here. Okay? So if you can find it in any precoordinates, VT. Maybe dissociation, VT. Now, and come down to the morphology. You cannot find any of them. He didn't include Josephson sign. Okay. Now, so then you go for the morphology. Now, if you read the Y complex is right bundle, okay. Now you go through the left rabbit ear taller than the right, okay. And at the same time, when you see this, it also helped the V6 small r, QRS. Okay. Now the left bundle type VT is more difficult when it comes to morphology. And this, V1, it looks complicated, but you can measure it from here to here, and then this notch here. Okay? So unless you have very good memory, I don't remember this. So I keep this whole image in my iPhone, and from the iPhone, okay, if I need to, I pull this up, okay, and for comparison. Okay? Now, so I advise you to do the same. Now, so let's talk about another type of VT. It's called accelerated idioventricular rhythm, that we call slow VT. I know it's a paradox, but you should remember that all the criteria, we saw the criteria of VT, but the rate is slow. Okay? Can be as slow as 50. Okay? Then you say, hey, how can you say that? It's tachycardia. Right? We just said, whatever my description. Now, it issues from enhanced automaticity, okay? And it's very commonly seen during reperfusion phase of an acute ST elevation MI. So it can be spontaneous, or it can be after a successful PCI procedure. So what happened is that the muscles now is getting, ischemic muscle now is getting blood back, okay? And it celebrates by sending out the signal, okay? That will wake you up in the middle of the night, because when they see it, the nurses will call you. Okay? You should self-limiting, and then you require no treatment, but always see the patient, okay? Now, sometimes even during a normal patient, you do a long-term recording in the middle of the night, vagal tone is increased, sympathetic tone is decreased, and these guys will come out, okay? Self-limiting benign rhythm, no treatment. Right. Okay, VF, okay. Now, let's look at this ECG. Okay, I'll throw you into to the rules. Okay, now Y complex. Let's remember, try to apply what we learn. Okay? So the first thing is to look at the QRS complex. It's wide, 120 millisecond. Okay? Now, another thing is that you do not see P wave in front of QRS complex, so we know it's not sinus. So you can conclude that you have a wide complex tachycardia. Now, so and you look at it. So questions are VT, is it VT? Is down, and what the history tells you that is most revealing. Okay, someone who's having an MI or someone who had a history of MI, older patient, when you have right complex tachycardia, VT. Okay, now, but let's apply what we learned. There's no delta wave. Everything goes very sharp, straight up. Okay, now this one, questionable. Okay, but this is not persistent. Okay, down. Okay, down, straight down. Okay, down. But you may want to shout out and tell me that, hey, this is VT. Why? Because you said, I saw skinny guys, among fat guys. Fusion complexes. When you see fusion complexes, hey, VT. All right? Isn't it simple? You may also want to show off your knowledge by pointing out something more. Now, what is next? Go to V1. Did you see 2 ears? I've already given you a hint that this part of those farther down, you still have the rabbit ear. Okay? To the left, taller than the right. Okay? And you have a right bundle type here, 12 wave in V1. And you can easily say that, hey, look, I have a small V6, small R, S. Okay? It's together. That's together. Notice also suggests VT. Okay? Usually we don't need to use that. Now what else? What else do we see? How about Josephson's sign? Okay? Can you see the notching? Okay? Now these are all extra icing on the cake, like they say, because when we have fusion beat, that's already VT. Okay? Now, so you said, Bugaba said, how about my sign? Okay? Now, you can recall the leads. You can pick any that fit the criteria from here to here. This one that is 100. But you can pick the one that's most obvious. Go from here to here. When 100 is 120. Oh, so yes, Professor Bugada, your sign is helpful. Okay? Now, so, you said, but I know even more than that. I want to show you the AV dissociation. Now, why do I suspect AV dissociation? Now, V1. You also notice that there's something trying to pop in and out. Okay? Here. Okay? This is most obvious here. Okay? Now, there may be a lot of P wave in between, but all you need to do is measure the interval, okay? Move it over from this point, either here, in this direction, or using this point in this direction, and exactly at the end of the interval, something comes up. So we already demonstrate AV dissociation. But if you want to measure everything, every P waves, you got it here. So this ECG, okay, have just about all the criteria that you want, want to apply. Okay? But either one of them will tell you SVT. Right? So isn't it a lot simpler than SVT? In fact, you see VT a lot more often. This one is a little more complicated, and this one, when it's so wide, unless the patient is hypokalemic, hypokalemia give you the wide scars complex. Remember that one. Now, it's a female patient in 60, palpitation, BP 108, systolic, and looking pale. Okay? And the first thing I would do is make sure that I treat the VT, the tachycardia, okay? And I quickly would send off for stat potassium. Now, but let's go over what we know too, okay? How about the width? Wow, 160. How about vital sign? Now, this one is easy to do, okay? This is R, this is a S wave, this is a T wave, from here to here. Definitely clear now. This one was the 200, splitting 100. So this already tells you VT. In fact, you know this history with this? Okay, I know it's VT. Now, then, this is not, you don't have rapid ear because this is left under branch type, okay, VT. Okay, so you can apply your, the configuration, the rule, not rule, the measurement that helps you make the diagnosis. Okay, the R wave is more than 30, and the R to the nadir is greater than 60. So you got it, okay? And what else? You also have notching, okay? It's the S wave. So it's called VT mix simple. All right. It's 11:42. Now I'm going to talk quickly. Okay, give me 2 minutes. Maybe we can just continue. How about treatment? Treatment. Now, unfortunately, that's not the way to learn how to treat VT and SVT because you want to be there. Okay, and so what I'm going to do is no different from reading from a textbook. Okay, so I'll just highlight what I have in my slides. Okay? I will go on. Okay, now treatment of tachycardia. The most important thing is determine if the patient is sick or not, is unstable or not, if wasn't sick. Okay? So clinical judgment come in handy. Okay? With time, you learn and improve your clinical judgment. That's what, after all, what the doctor should do. Okay? So the most easiest thing is a patient tachycardia with ischemic chest pain, and mental changes, issue that is way bad. Okay, hypotension, hypoxia, okay, acute pulmonary edema. Okay, and the tachycardia. Better take care of the tachycardia. Okay, ASAP. But doing a 12-lead ECG is very important. Okay, because by now, with 12-lead ECG, you can have a very, very good idea of what you are dealing with. Okay, whether it's SVT or VT, whether it's atrial fib, okay? Whether you're dealing with accessory pathway. Okay? So even though it could be a chaos when someone come in, people start to panic when someone has tachycardia, especially Y complex, do a 12 leads. Otherwise, you're working in the dark. Okay. Now, so this is just ACLS. You know that pulseless VT, defibrillation, epiphysic shock. We show you, defibrillation means we don't synchronize, and and we can give amiodarone and and magnesium sulfate. Magnesium sulfate is very useful for someone with torsatilprone. Okay? It's another treatment for torsatilprone recurring if someone has sinus bradycardia. Torsatilprone can happen in someone with complete heart block when they're very slow. Okay? And by pacing, temporary pacing, we bring out of the heart to 80, 100 beats per minute, you can prevent this from happening temporarily. Now, why complex? Now, it's a little bit irrelevant. No, it's not as now because we know, from this lecture, hopefully, a good idea whether we're dealing with VT or SVT with aberrancy. Okay, so yes, and stable shock the patient. Okay, synchronized shock. Okay, and now sedation is important. Okay? Now, when you shock the patient, why is it so important to synchronize it to the R wave to deliver the shock and R waves? Because there's such thing as the vulnerable period. Okay? So if you have even a VPC in a bad situation, like QMI, Brugada syndrome, severe potassium abnormality, this can trigger VT or VF. In fact, in the EP laboratory, now besides pacing the patient rate at 300 beats per minute going VF, we deliver a very tiny shock right here, and it will go VT, induce VT. But your job is rescuing the patient and not do this. So that's why you have to synchronize it. Otherwise, you deliver a shock like 50 or even 60 or 80 joules externally, and it happens to fall here, then this guarantee you this can happen. All right. Now, there's another thing I want to teach you, okay? And I think a lot of people overlook it. Is that when you do synchronized shock, and when you press the button, keep the button pressed until you see the shock deliver. Okay, either on ECG or you can see the patient. Now, why is that? Okay, because the second you press the button, the machine will look for the next synchronized R wave. But if you let go, okay, before you find the next R wave, okay, it will stop. The machine will say, oh, okay, he doesn't want me to do it. So don't just touch a button and let go. Keep it pressed, okay? In VF, is that VT is fast VT, it's usually not a problem, but if you want to calibrate atrial fib when it's not that fast, or when the rhythm not fast, you may let go in between the QRS complex. So remember this, okay? Now, so this is Torsade, and you can see this is for the R wave, and this is classic Torsade ECG. Now, so why complex the patient is stable? Then you have to do more. Now, you have time to look at the ECG to determine whether it's supraventricular or even whether it's AV and RT. No, or sinus attack or with under branch block or aberrancy. Okay, so vagal maneuver, okay? And you can terminate reentrant tachycardia by disturbing the relationship between the fast and slow pathway. Okay? And so increase sympathetic tone. Okay, you can do it Valsalva, carotid sinus massage, or in fact, it's easier. You can give adenosine. But with Y complex tachycardia, be more careful. Okay, always careful. Be more careful when you use adenosine. Okay, now it's very short half-life. Okay, so 6 to 12 milligrams injected rapidly into a large proximal. Okay, what's proximal? As close to the heart as possible. Okay, followed by a flush. You want it to get into the heart ASAP. You don't drip it in. Otherwise, by the time you get to inside the body, it's deactivated. Okay, you want a bolus. Okay, you want a bolus to get, so that to work on the AV node. Okay? So it may terminate SVT, AVNRT, or AVRT, but it can translate slow, okay, down AV nodal conduction. Okay? We may not terminate the tachycardia, for example, sinus tach. Okay? You won't be able to, you don't terminate sinus tach, but you can slow it down, you can see the P waves. Atrial tach, atrial flutter, that's very important. Now, in the diagnosis of atrial flutter, especially 2 to 1, you slow down the AV nodal conduction, it can go to 4 to 1, 8 to 1, even 10 to 1. Now you can definitely see the P waves, or the flutter waves. Okay? So, you usually don't need that. Okay? Now, there's some VT you could actually terminate with adenosine, but I would rather you not to try it, okay? But be expert do it, because most of the time, this is rare. RV alpha try VT, and if you give adenosine to patient VT, you can really drop the blood pressure. Now, here is a caution. This is very rare, okay? But I need you to know that it can convert antidromic, even if the entering tachycardia, okay, to AF. Okay? When that happens, with your antidromic, you can have the same disaster, but very rare. But it brings up the important point. When you do treat tachycardia, you always have a defibrillator ready. Okay? Now, so then, right complex, this is almost the ACLS protocol in Yoderone procainamide. Okay? Be careful when you try, okay, good in Yoderone pressure together with beta blocker. You could cause AV block and different sinus asystole or, okay? And the scary part is that it doesn't happen, okay, in front of you. Sometimes you send a patient home on amiodarone plus a beta blocker. I always caution against that. Patient may come back with heart rate of 40. Now, narrow complex. This requires, this you come across more often. Patient is stable, of course, you shock the patient. Our salvo will help with medical diagnosis. Adenosine definitely is very helpful. Okay? Sometimes, again, it's what we call abundance of caution. Maybe I should include this. They may induce AF. Small percentage, very transient. And the narrow complex, nothing to worry about. Okay, I just want you to know that it could happen. Now, so if adenosine fail or after, it's go back to sinus rhythm. Sometimes even 2 beats, and then return. Kind of return, and you should just try to control the rate for now, okay, which calcium channel blocker, beta blocker will work. Okay? But sometimes you're dealing with this dynamic. Someone had heart rate 150, say, for example, it's narrow QRS complex. Okay, and then it's a tachycardia from your heart, and there's a hypertension from your tachycardia. Someone cannot tolerate faster heart rate. So you on the one hand, you are told not to use beta blocker or calcium channel blocker, okay, because the patient may become hypotensive. On the other hand, stopping the tachycardia will slow the heart rate down and the blood pressure will improve. So now that becomes a matter of clinical judgment. And there's unless it's in the bedside or low life situation, it's very difficult for me to tell you when it is, when you should use it or when you shouldn't. Okay? But I think, you know what? If the blood pressure is 100, I would do it. Okay, 80, I would think twice. Now, so this is my table for adenosine in treatment. Again, abundance of caution. Narrow complex tachycardia, yes, no problem at all. Okay? Wide complex, Be careful, very careful. Okay? We know the outflow tract VT, usually the QRS complex is positive in 2, 3.5. Okay? Well, you can use it. AF excitation, definitely not. Okay? Now, so let's move on. How about chronic? Okay? Now, treatment of tachycardia. Okay? So you have to identify reversible contributing factors. Okay? Someone who like to drink, someone who's hypothyroid, for example. Now, then there are so many options. No treatment. Hey, yes, that's a very important option. Sometimes treatment is bad. Anti-arrhythmic drugs, okay, in certain situations. Then the 2 procedures is very important: catheter ablation and implantable devices. And we'll go and talk a little bit more. I mentioned catheter ablation, in AF talk, and it's invented in the early 80s. And then we have catheter, and it's modified from the diagnostic catheter. And you're able to say, now you can be connected to a radio frequency generator. Some of you may have gone through surgery, may have even gone into the operating room, and you see the surgeon, pick up something like a pen, and when they see excessive bleeding, and not really a lot of bleeding, oozing, and you can burn the skin, burn the muscle, okay, and you stop it, and it's the same principle. So you heat up to 50 to 55 degrees centigrade at the tip, then you can burn tissues, myocardial, any tissues. And so the idea is to find the sensitive pathway, burn it. Okay? Find the slow pathway, burn it. And that's a very powerful, they may provide definitive cure. Okay? So now it becomes treatment of choice for SVT, okay? Especially patients with recurrent SVT, symptomatic SVT. Also can be used to treat atrial tachycardia. You burn the focus, flutter, okay? You go around in circuit, you say, okay, this is the best place. I'm going to burn so-called bridges. Burn the bridge, and you cannot go around. Okay? And even tachycardia, okay? VT. So that's one treatment. The other one is defibrillator, ICD, internal cardioverter defibrillator. And it's a pacemaker and a defibrillator together. Now, so it's implanted in your heart. This is the most common one, okay, under the skin, and you either 2 wires, okay, one in the atrium or one ventricle, or just one, okay, and no, it's none in the atrium. There's no difference in terms of performance diagnosis whether it's 2 or 1. So the key is that there's a coil, okay, right here at the distal portion. Now this proximal dual coil array configuration is gone. We don't do that anymore. We find out that it only causes more mechanical problem and without improving treatment. So we just use this one, and this is like a paddle. Okay? So you deliver the shock from here to here. Okay? Now, then there's another one. Okay? If you examine the patient, always look for lumps. Okay? Whether here, sometimes it's here. Okay? And it's bigger under the skin, and this advantage of not having to invade the heart, and also the brain vessels. And this is subcutaneous. You deliver from here to here. Okay? It requires more shock, much more, and there's no effective pacing. Okay? Now, so it's called SICD. Now, so how does it work? What happened? You are the boss. You pre-program, okay? How the defibrillator will respond in the, when it sees a tachycardia. Okay? So usually you divide them into different zones. okay, by rates. Okay, the fastest rate is it's a VF zone, and then you can have one zone, one VT zone, two VT zones. That's when you become your clinical experience and the patient's history, okay, come into play. Okay, now so you said okay, VT zone is slower, so I have more time. So you can try anti-tachy pacing. Now this ATP is not the same as adenosine type ATP. It's anti-tachy pacing. And or you can say, okay, just deliver shock but less. Why you want to use less energy? Because every shock hurts. Yeah? So now, if this doesn't work, or you can pace the patient from a slower VT to a fast VT, going to a VF zone, then you can just say, oh, deliver a big shock. Okay? Now, it's all pre-programmed. You don't do this when the patient is VT because usually it happens at home. Okay? Now, let's see an example. Now, this patient will have only one lead. Okay? There's no atrial lead. So, and this is reported, across the catheter angle, and this is from the tip to the defibrillator. And this one is provider. Okay? So it only go. There's some criteria, but the most important one is rate. Okay? Now you already know the patient's usual VT rate, and they said, okay, if the cycle length is more than 330, shorter than 330, 330 shorter, I call VT. Okay, it's you're the boss. And then when it happens, okay, I will tell the defibrillator, the pacemaker part of the defibrillator will rapidly pace, T-pace, okay, tachy pace the heart. And sometimes, often, you can terminate it, and the patient don't feel the pain, and you successfully treat VT. Now, but there's another example here. Now, this one, the patient have a so-called dual chamber ICD, a lead in the A and the lead in the ventricle. Now, you can clearly see the AV dissociation here. P wave, QRS. Okay. Now, so you said, oh, okay, I pre-program it. When this happened at this rate, VT zone, ATP. Unfortunately, in this situation, it failed. Now you can continue a few times, okay? And in this situation, in this case, the doctor said, no, when I tried once, it doesn't work. See, it's still VT. I'll give him a shock. Shock is delivered, and it works. That's how it works, okay? And I think did we look at the price tag? Yeah, this is about $18,000 or okay. So all right now, so let's come back to when do we use antiarrhythmic? Do not use antiarrhythmic for VPCs. Okay, and we learned it painfully. Okay, and we used to, when before this paper came out in the early 80s, we treat because we correctly identified VPC as a poor marker, okay, of mortality. Okay, so we said, okay, we'll treat it, and then I think will happen, and we've been doing that. Turned out that it shows that yes, when you treat them with like at least sodium channel blockers, yes, you suppress the VPCs, but you actually increase mortality, okay? Twice, you double. Now, this group of patients is, have prior MI. Okay? So it becomes it's so disruptive and due to a big surprise. It's actually a landmark study. So after that, we expanded to any class 1 sodium channel blocker for just suppression asymptomatic VPC. We don't do it, okay? Especially in someone with ischemic heart disease. poor LV function. Okay. Now, so asymptomatic VPC, we definitely don't, in general, we really don't treat. The only time we will treat symptoms, but you really have to convince me it's asymptomatic. Okay? And now, so in high burden VPC, there's something called, like, when there's more than 20,000 per day or more than 10% of your beats, total beats of VPCs, then you may consider treating it because it can develop with cardiomyopathy. Okay? So, and also we know that treating high burden VPC can reverse LV dysfunction. And usually we use beta blockers, and in healthy patients, healthy heart, before they develop cardiomyopathy, we can use drugs. Otherwise, ablation. Okay? This is not a situation in general you need to deal with, but if you have someone with a lot of VPCs, think about sending him to see a cardiologist. Okay? Now, so anti-arrhythmic drug, when they use VT for VT and VF. Okay? So basically, the only effective treatment in preventing VT and stopping VT and VF is basically defibrillator. So, but then we cannot afford, $18,000, actually US, okay, on everyone, okay. So you identify the high-risk patients, okay. The most common ones that we deal with are the ones with coronary artery disease, either obstructive coronary artery disease or patient have a previous MI. Okay, usually they come together, and they have depressed LV function. And so, what is depressed LV function? About 30%. Okay? And when and measure about 40 days after an acute MI, okay? If there's one. Why those patients are high risk? Well, because the study showed that 2 years mortality rate is 30%, and mostly from sudden cardiac death. So these patients are candidates for a defibrillator. And also we shown that defibrillator actually reduce mortality. Now, why do I grade out frequent VPC? Because in 1 and 2, you almost always have this. Okay? So you can try beta blockers, right? And consider ICD. Okay? Now we have this all done in the 80s, actually 90s and early 2000s, comparing defibrillator to drug therapy. Okay? And they all come out ICD being superior. And there are many situations when you consider using ICD. What I listed here, 1, 2, 3, 4, 5, 6, these are class 1 indication. And they said, yes, you should do it. Now, and but you need to also consider patient individually. Prior MI, 14 days ago, and LV function is less than 30. Or patient doesn't have ischemic heart disease, but cardiomyopathy, less than 35%. Most people would do it. Now, congenital long QT, high-risk patient with hypertrophic cardiomyopathy, ARVC. Not everyone, okay, but they classify high risk. Okay, then will seriously consider ICD. Okay, now, sometimes, in situation when you don't want to do it, and you can use, others can read up on it, okay? And secondary prevention, especially means the patient already have a VF, VT risk, definitely ICD, okay? And we need to go down quickly. When do we use antiarrhythmic drug? Now, if we don't treat VPC, we definitely do not want to treat APCs. We talked about AF already. Now, atrial flutter treatment is the same as AFib, okay? And tachycardia. Now, see, no treatment for ABCs. Okay? Now, how about the SVT? Okay? Atrial tach, you can use, beta blockers. Okay? And, a lot of choices. Okay? And AVNRT, okay? Narrow complex, cath ablation. Okay? And that is treatment of choice. Okay? Imagine a young person, okay, and who get recurrent AVNRT, and you might as well give them a cure with an ablation. We talk about acute termination, chronic, because it's narrow. You can do beta blockers, and if usually they're healthy. With a healthy heart, you can use sodium channel blocker, and without any problem. Okay? So even amiodarone digoxin. Now, how about AVRT is narrow, and it's basically again ablation. Okay? So and the treatment basically is the same as narrow QRS complex, AVN and RT. Now, so why complex? Let's be careful, okay? And okay, oral amiodarone is okay. Okay, IV, I would worry a little about it. Okay, so again, this is all reading. I don't want to read again. Now, this is AF, antegrade conducting accessory pathway. Okay, we talk about this. Okay, and acute termination, synchronous DC calibration is the best. Okay, and if you want, and you have to, you can use IV. Chronic suppression, okay, we always like to do cath ablation to get rid of the accessory pathway, so that we don't have to worry about going into rapid AF through the accessory pathway. Okay? Acutely, AF, rapid response, antegrade conducting system, no IV amiodarone, no adenosine, no digoxin, nothing that acutely attack the AV node. All right. Okay. I think towards the end, we'll go through an example. We'll see more example late in the first session. Now, a 70-year-old woman, come to your clinic, depends on where you're practicing, let's say 10 years from now, whether you are in Central or Zhonghua, okay? Or PW still, okay? So she reported that she was hospitalized for severe crushing chest pain 8 months ago. Now, history. I keep saying that. Now, when you get that and you think about a prior MI or at least ischemic heart disease. Okay? So she walked in, okay, no significant symptoms, but feeling a little bit more tired than usual and through palpitations since this morning. BP 110 over 80. Of course, you check the pulse and wow, it's very fast. You did a 12-lead ECG. Okay? Now, so let's test attention span. Okay, remember. Okay? Let's identify the following rhythm. The first thing you would tell me is that it's VT. Why? Because the history presentation. Okay, elderly woman with most likely a prior with coronary artery disease. Okay, white complex. But let's go through the checklist. Okay, now let's do that. Okay, measure the QRS in the flow. Now, I don't see any delta wave. Okay, you see how sharp this is. How sharp this is. Sharp. Okay? And this is considered sharp, and even this is so sharp. So when we measure this, now it's 160. Okay, suggestive. Now, also you notice it's -1, positive AVR and negative L. So you know that this is a northwest axis. 2 characteristics that point towards VT. Now, so do I see fusion beats? No, they all look the same. Can I find recurrent deflection that looks like P wave, so that can determine AV dissociation? No. Okay? Now, then you may already want to tell me, okay, what you saw. Okay? Rabbit ear. Okay? First taller than the second. Then you got VT. All right? Now, then you said, now I should learn more. I do the Buddha sign. 150 VT. And also, whenever you're this, and you may also want to look at V6, RS morphology. So you already got it. That is VT. You don't have Josephson sign because no notching that you can tell. Okay? So but you have enough to say, okay, this lady has VT. Now let's go over it one more time. Keep repeating it so maybe you can retain information more. QRS width 160. Yes, if it's VT, but it may not. It's not diagnostic. QRS axis, history and age. Okay? Now, we have precordial ECG concordance. No. Negative or positive, no help. AV dissociation, I cannot identify P waves, no help. Right? Capture fusion complexes, as I mentioned, none. Now you get the Brugada sign. Okay? Yes, VT. Yeah. Notch downstroke near nadir S wave, no. Josephson sign, no, doesn't help. Rabbit ears help, this help. So your VT. Now, one thing to make the diagnosis, another thing to treat the patient. How would you want to treat the patient? Okay, what will you do next? Now, if you are in your office and your office is not emergency room, okay, monitor the BP, okay, and call for an ambulance. Don't tell him to go in the emergency room by herself, even though the patient is stable, because she's stable at the moment you saw him or saw her. Okay. Now, if you are in a clinic or in A&E, okay, what you do? Now, you sign an IV. Always sign an IV. When you sign an IV, send off blood for routine, okay, blood test, okay, and potassium especially, and also for troponin. Now, it's unlikely the patient has MI, but it's good to be safe. Now, and also why you want to send it off first? Because after you shock the patient, oftentimes troponin will go up because the shock, does destroy some myocytes. Okay? So get a clean picture, send off the blood first. Now, would you shock the patient? And since we cannot, with the Zoom, I cannot, press you for an answer. No, because the patient is stable. Okay. Now, so, but always have defibrillator ready. Okay. Drug treatment. Now, would you give adenosine? They quick short answer is no, because it's VT. This is why it's so important to get 12 the ECG, look at it, you're doing VT, and you're not doing with alpha track VT. Don't give adenosine. Similarly, don't give beta blocker or calcium channel blocker, because in the VT, okay, with the exception of your alpha track VT, when they will only bring the blood pressure down. So that left you with the last one, IV amiodarone. Okay, and you take care of the patient. So from that diagnosis to treatment. Okay, so we'll stop at this time because it's 12:19, and unfortunately we couldn't go up to see patients. And so when you we'll see. I think when do we meet again? The next one about ECGs again. That's out of the three. I think that's the most important, and try not to miss it because it will help you, okay, to stay out of the news. Okay, I'll go over heart block and acute coronary syndrome again, without showing ECGs, that it's not as obvious, and also approach to making the diagnosis. So let me see. Oh, I'll see you Friday. Okay. So, any question? Hello? No question? Good. No question. All right. Okay. Let's break. And 你哋食飯啊？而家點樣食飯法啊？尤其是你係under 嗰個咩啊？isolation 有冇人拎飯俾你食啊？哦，擺喺門口啊？因為我我2020年嗰時候啱疫情開始嘅時候，我有咗人翻咗美國，咁跟住話4個月後先有飛機翻嚟。我翻嚟嗰時候咧，都隔離咗14日又係啲嘢擺喺門口咯咁你要幾耐日啊？咩叫初診啫？咁第一次 check 到 positive 就 positive， 你係嗰個係 fast test positive 定係 PCR positive 啊？係咯，咁樣咁減低啊嘛？因為睇到佢係個 CT value 高，係咪高級先係好啊？我都咁佢即係冇話決定話係你要幾時 retain isolation 幾耐？咁好過以前咁啦，好過以前係咪都要 isolate 兩個禮拜啊？係 good luck 咁啊！就我哋個個都而家都少啲出去食飯啦，真係。不過呢個時候我唔係 expert 即係好多 expert 都唔係 expert 咁啊，真嘅。即係你 you cannot have zero cases a case anymore. It's just too infectious. All right，咁我哋禮拜5再見 ，OK？ 係 stay healthy, try，OK？ 我都唔出街路。好，有個 question 係乜嘢咧？係thank you. I always appreciate your teaching you guys. Too bad we cannot be more interactive. All right. Okay. Bye bye.